Does it decay by beta only? Strontium-89.
Yes.
Good. Does it behave like calcium?
Yes.
And is the dose 4 millicuries, slow IV injection, or 40 to 60 microcuries per kilogram of body weight?
The second one.
True. That's how strontium-89. What is the one that we use that has both gamma and betas for the bone therapy?
The
It's not strontium-89. It's what?
Quadramat.
Yes. So what is it? It's also called Samarian 153, right?
Yes.
Good. All right. Is technetium PYP, or has it ever been considered a skeletal imaging agent? Yes, technetium PYP could be. We used it years ago. How about calcium 47? Yes, that's another one. Could use for a bone. How about strontium 87? Yes, back in the day. How about indium 111 white blood cell? Can we use that to look at the skeletal system? Yes, in a different way, looking for infection. How about technetium sulfocolate? Is that skeletal? Yeah, we look at bone marrow. Good. How about F18? Do we have a PET tracer that can look at bone? Yes. The answer was yes to all of those. All right, good. You guys did that. You did a nice job on the review with the osteosarcoma.
We're still zooming. Sorry.
Yes. You got the number of bones in the body. You got the single breath, the equilibrium and washout on the pulmonary. What's the name of the lung scan we do pre-surgical for patients needing to remove a portion of their lung, usually for cancer, not always? What's that name of that exam?
Lung quant.
Yeah, so if you got a lung quantification scan, good. We're on to exam 3 already, which was your third. What's the duct that leads to the gallbladder? Anybody?
Cystic
duct. Cystic duct, good. Common bile duct carries bile from the gallbladder where?
Small intestines.
Good. Duodenum or small intestine. The cells used when imaging cholecystography. Which cells?
Hepatocytes.
Hepatocytes. Good job. All right. Those. Good. You've got that. Morphine sulfate increases gallbladder filling. True or false? True. Normal T1/2 for a gastric empty. How many minutes is a normal T1/2 for a gastric empty?
50% empty by 90 minutes. No.
Okay, so 90 minutes would be a normal T1/2. The range might be 60 to 105 minutes. Okay, that might be normal range. Good. What's the most common presentation for Meckel's? What's the patient complaining of?
Bloody
stools. Yeah, they notice blood in their stools. Good. Where's the most common location for Meckel's?
Right lower quadrant.
Good. Where's the most common pain for gallbladder problem?
Right upper right quadrant.
Good. All right. Good. We went over that. We went over all of that. Yep. Good. That's next semester. Keep that out of your brain. All right. Good. Which exam will we be doing if we added a little bit of hydrochloric acid?
Reflux.
Gastroesophageal reflux. Excellent. Good. Excellent. Okay. So you covered everything else for the GI. The GI is done. So let me just kind of show you. We went through all of that. That's excellent. Make sure you look at the key for myocardial perfusion. My last thing I will show you I'll just bring it up so you can see what it is. Let's see, final review 2020. This is available now. Get on here, share screen, show you. So this is the review that I just put together. I think you guys did a good job and probably covered all of this already, but you can look through it, you know, name the method of localization, particle sizes, so you can kind of look through this with the exams. So just real quick, tell me what exam this is.
Thyroid.
Thyroid. You can recognize that. This is marking the chin. This is marking the suprasternal notch. It's a hot marker, taking various views. Good. Recognized it. How about this one? What's this?
Salivary gland.
Is it salivary?
Take a look. I'll let you think for a second on this one. What do we see in the picture? First, start with what do I see? Okay, I'm positioned somewhere around the neck and chest. I see a heart at the bottom of the screen. I'm seeing some salivary activity up here and a thyroid in the middle. And I see I've got kind of blurry initial images, and then it looks like 2 or 3 hours later.
Parathyroid.
Thyroid.
It's a parathyroid. Excellent. Okay, so we're seeing this uptake here. And do you see anything? It looks like there might be something right here, right? At the bottom there. Okay, so if I gave you this on a final, you might say, well, it's hard to say for sure, but it looks like this. It looks like the tracer leaves all the area except for the bottom pole, and just kind of explain what you see. As long as you explain it and you understand what you're looking for, you'll probably get the credit, all right? How about this one? What's this?
Gastric
Yes.
empty.
You got it, okay? So that's the stomach. How about this?
Liver spleen.
Liver spleen, okay? So go through this and make sure you can name the exam, the indications, the dose. How about this one? What exam is this?
Liver spect.
Liver spect. It's right there. I mean, couldn't be any easier. All right. How about this one?
Whole body bone.
Yeah. Okay, so go through here. How about this one? This is a tough one, actually.
There's
What do you think?
GI bleed?
I injected this patient. It's talking about something about pneumonia.
so long.
Lungs.
We're looking at the lungs are lit up and they have an infection in their lungs. This is actually a gallium-67 citrate scan, and the patient has AIDS and they have an active PCP infection in their lungs. We're going to talk about this one next semester, but this is a common image I like to show you. We'll talk about it later. How about this one?
Meckles.
Eccles. You guys are going to rock this out. How about this one? What's this?
Haida.
No.
Yeah, hepatobiliary, you've got it. And on here, there's sometimes I give you clues. 2 days post cholecystectomy. Hopefully it gets that it's a HIDA, but it's for bile leak, right? So we don't care about NPO, we don't care about morphine, nothing. You go in, this is stat, let's find it. It's obviously an issue. We see all these spots here, that's bile leak. We got a problem, okay? And move our faces over here. How about this one?
Perfusion. Lung perfusion.
Lung perfusion. Like a chunky monkey to me, right? Segmental defects, what would we call this? How would the radiologist call this?
High probability.
High prob, most likely. Obviously, I didn't give you all the information. Good. All right, next. What's this one?
Heart? No.
Mug.
It's a heart. It's a heart. Absolutely. This is the left ventricle of the heart. The right ventricle's over here. This is an LAO view. What exam is this? This might be the only exam
Mugga.
Auntie would see at her site. Mugga or Erna. This is just looking at function, just looking at that left ventricle, getting the left ventricular ejection fraction. Okay? If it was a stress rest, we'd have the lines, the resting lines and the stress lines, comparing the blood flow in the different slices. Good. What's this?
Lympho.
Lympho. Good.
No node, yeah.
Good. Yeah, that was actually, I think DeMonte did a lympho. How about this one?
GI bleed.
You guys are so good. Excellent. You see the heart at the top, you see the liver, and you're looking at the vessels in the area where this is positioned. This is a GI bleed, looking for a bleed. Good. You remember this? The MDP and the indium. We talked about that. Okay. Which one uses the abdominal cuff, pressure cuff? What is it?
It was a gastroesophageal reflux.
Reflux. Good. What's this one, guys? This is a tough one.
Is it, it's one of the infection ones.
No. Good guess, because it is a whole body.
Is it
What do you see lining up? So whenever you're at one of these and you're like, heck if I know, or you're not sure, go back to distribution. Okay, I'm seeing activity, nasal region, salivary, neck region, stomach.
Great protectate. Right?
No.
So
This is actually, I probably won't give you this one, but you never know. This is a thyroid whole body. This is a thyroid whole body. This is the thyroid region. We got probably some METs here. Need some follow-up, but this is how it will look, the whole body thyroid. They're trying to determine, what the heck is this thing here? Uh-oh. That might be some kind of spread of cancer there. Okay, so that's an I-131 whole body. I'd have to give you probably some more information on that one. Okay. Metastron, Quadramet, what do we use those for?
bone therapy?
Bone therapy, you guys got it. All right, what's this?
Salivary.
Salivary, it's on the slide. Yeah, good. Compartmental, what are the ones that have compartmental?
GI bleed? Gastric empty?
liver schema.
Good, excellent, and we'll learn some more next semester. Chemi absorption,
Bone scan.
bone scan. You guys know this, right?
Yeah.
NP59 is what? For what?
Adrenocortical.
Adrenocortical. You're not going to miss that one. Anyone that's left right now, you guaranteed to get that question. All right? This one's what?
Medulla.
Medulla, adrenal medulla. You guys got it. Osteomyelitis. Okay, tell me which ones can be used for osteomyelitis.
HDP, MDP.
So, HCPMP. We can do a bone scan. Let's say the bone scan's inconclusive. What's next?
Indium 111.
Indium 111, and we can even combine it with
Sulfur colloid.
sulfur colloid to be sure if we see something light up. And then we also can do, but we do it last because once we give this, we got to wait 3 weeks to do anything else, is what?
Gallium.
Gallium-67 citrate can also be used. Good job. Good. We talked about this. Graves' disease, 10 to 15. Toxic nodular goiter, that would be a little greater, right? We said 15 to 30 millicuries. Localized thyroid cancer, 100 millicuries. Thyroid cancer spread to the lungs, probably 150. Bones, 175 to 200. Okay? Doses for these, I went through these, right? We went through these today. So, but you can go back and look through them, make sure you know them. Okay? Make a list of the exams, the radiopharmaceutical energy half-life. I think you already did that. I mean, you guys have really reviewed well axial versus appendicular, pheochromocytoma. Remember, you got the two tracers we would use. Reversing vasodilators, aminophylline. All right. Patient prep before the 3-hour delayed bone scan. What are we going to do? When they come back, what's our job when they come back? Hey, I'm back. I just went shopping at Macy's and had some lunch. What are you going to tell me to do?
Have them empty their bladder.
Go empty your bladder, please. Give the old college try, even if you don't have to go. And then what else are you going to do to me?
Empty pockets.
Pockets. Yeah,
Take off
you
the
know,
belt.
I could be like a coin lover and have a pile of coins in my pocket. That's right, belt, coins. I might wear suspenders. You know, you got to get it all out. Good, excellent. Prep for thyroid uptake and scan. We talked about that. Don't forget the NPO. And Francesca mentioned like the green leafy vegetables, the no fish, no seafood weeks before, right? No thyroid meds, all of that. Gallium and perfusion tracers. Can you guys answer this now? Gallium is that redistribution agent. We can inject it, take some initial images. If we see a defect, a decreased area of blood flow, it might mean infarct. or it might mean ischemia. We can do a 3 to 4 hour redistribution image and determine, is it still viable tissue? If it is, it'll fill in an activity in that area, and then the patient will be a good candidate for surgery. Okay, whereas the technetium tracers, they kind of remain fixed in the myocardium. Okay, we talked about that. Exercise treadmill, got to continue for at least 1 more minute. Okay, MUGA, it's to see function, especially left ventricular ejection fraction, function, wall motion, all of that. Stress test is for myocardial ischemia, perfusion. Want to see perfusion? We do a stress test. We want to see just function, ejection fraction, we do a MUGA or an ERNA.
I
Okay?
have a question about the cardiac.
Yeah.
So I thought when we were doing the rest and stress, wasn't it like you can also tell if there was infarct versus ischemia based on like what part
Yes.
had uptake on the rest exam and stress? So is that not the same thing as the thallium?
Yes, so
Like,
the technetium works differently. We cannot get information on hibernating tissue, which is tissue that appears dead, appears hopeless. So on the, let's say you did a patient, and it's, most people don't use thallium anymore. You did the stress and rest, the myocardial perfusion. Everyone can picture those slices, right?
Yeah.
And you see a defect, whatever, in the inferior wall. And on the resting, there's a defect. And on the stress, there's a defect. The same defect is in the stress and the rest images. The radiologist will say that's most likely a fixed defect. It's irreversible, cannot be reversed. It's a myocardial infarction. It's on the rest, it's on the stress, dead. Okay? If a patient has something like that, the radiologist might actually suggest, or cardiologist or doctor, hey, let's do a thallium image of that area, because there might be some tissue that's still viable that we're missing. So
Okay.
they'll inject them with thallium. The resting image most likely is going to show just like the technetiums did. There's no blood flow to that area. But if you wait 3 to 4 hours and take another image, or even out to 24 hours and take another image, there is a slight chance that that area actually starts perfusing. So that's a special case where it's like from the Princess Bride movie, you know, it's not totally dead. It's partially alive, okay? So they can go in and they can see, on that case, the thallium image initially would be decreased, but then on the delays, it starts to fill in just a little bit. So guess what? If the patient's a good candidate for surgery, they'll go into that vessel and they'll open it up, and it might reperfuse. It's not totally dead. It appeared to be dead, but it's not. It's called hibernating tissue. Does that make sense?
Yeah.
We'll kind of go into it more detail next semester. But yeah, on the technetium one, they would just call it a fixed defect. Don't mess around with it. Very few people fall into the category where they think they might need this redistribution imaging. It also can be called a viability test. Viability test, we'll talk about that. That's with the thallium. They can tell if it appears dead, but it's actually still viable. There's a little bit going there. Yes, it's almost dead, but if you get it in time, it can bring it back to life. Very few people fall into that category. They look at a whole bunch of criteria from the massive amount of data from the stress and rest test, and if they see something particular in certain locations and EKG and all of this, they say, you know what, let's do this. Let's do the thallium viability test. And there's a PET version too of it. You can do it in PET as well. Okay, does that help? I know it's a lot. Cardiac, a lot. So like I said, as far as cardiac review, go to the first assignment that I gave you, November 9th. Look at the key. I think all of you did well on that assignment. Know the tracers, know the main difference. I put them in that PowerPoint. There's not going to be a whole lot on cardiac. Okay, just the basics of what we covered. Okay. I can't even remember if I gave you ejection fraction. I might have had you know the ejection fraction calculation. Did I have you do
It's on
that?
our-
I don't even know if I did, huh?
I think.
Yeah, we had to do it for math.
For homework, right?
Yeah.
So maybe know that, but it's kind of common sense one. It works like the lung, same thing. Okay? You guys did very well in your review. If you feel comfortable with what we just went through, you're gonna knock it out of the park. Okay? And remember, there are gonna be images, and you guys did a great job. I don't know who it was. Put the images in there. I'm gonna pick from the same images you've seen most likely. You know, we'll have some images on the test. You'll have to be able to identify it. But you guys, I pulled those up. You weren't like, oh, is that a lung or a thyroid? You knew right away what it was. That's what I'm looking for. But from there, if I show you the image, I might say, hey, what's the dose? I might say, hey, what's the indication? I might say, hey, what views are you going to take? Okay? So, but you guys really did well. Really. So, keep it up. Tuesday, you'll wrap it out.
Amy,
So
I
you-
wanted to ask you something afterwards.
Yeah, no problem.
I had a quick question too about the review that the PowerPoint that you just showed us. You included the lympho image.
Yeah, that was just to see where you were at.
Okay.
That was, Demonte did a lympho. I probably won't be as mean as to include, next semester I probably will be as mean. As to include student presentations.
Okay.
I might give you one question about student presentations, but don't spend your whole time studying everyone's presentation. Next semester, I'd expect you guys are on the ball. You got it down. You know what's going on now. You're not going to have the central anatomy class. You'd be able to, if I threw up somebody's presentation on an exam, you'd be able to say that's info. You know, I probably won't give you that one, to be honest, but just wanted to see where you were at with that.
Okay.
Can you recognize it? You know, but you did brain death. You know, if I threw a brain up there and it was the brain death one, I would expect everyone that sat for your presentation could say, well, clearly that's of the head, and we didn't cover that, but we did have him that did brain death. So I'm going to go with brain death, you know. Am I going to ask you details? No. Maybe that would be a multiple choice, you know, at this point. But don't focus too much on the student presentations this time. I might ask one question. Okay, so it won't make you or break you. Okay? How do you guys feel about procedures? I think you guys got it. I mean, it's just the same questions over and over. We're gonna block the thyroid. Are we gonna be NPO? Is it compartmental? ME absorption? There's only so many exams we did, okay?
The review today helped a lot for sure.
Good, bringing it all together, right? Good. And just you guys, I could tell when you did your reviews, it was fantastic. I almost was like, oh, I didn't need to do mine. They got it. You guys got it. You pulled out the key points. So good. I feel comfortable with what I heard from you and how you were able to answer. So I think you guys were good. All right. Any other questions? No? Okay. Well, let me know if you guys need anything. Otherwise, I have no doubt that you will do well. And then Thursday, like I said, we'll review for physics. Okay, so you'll be ready for physics as well. We'll do the same thing.